Hello, I'm Penny. I'm the Managing Director of Q at the Health Foundation. Really kind of thrilled to be here and have the opportunity to chair this session looking at how to improve waiting lists equitably. Our kind of peer learning events, the resources that we're putting together are designed to help kind of senior leaders in provider collaboratives develop shared improvement approaches that have a kind of embedded focus on equity from the outset. What we're learning from the work we've been doing so far is that this is emerging territory for most people. So our focus in these sessions is to help you learn from elsewhere and reflect together on the role of senior leaders and how that learning can apply to the work that you're doing in your provider collaborative. So it's really a place to kind of surface, reflect, share with peers what you're learning, the kind of barriers, the enablers, the opportunities that there are. So very much kind of work in progress rather than kind of polished final product. In Q, we're really delighted that we're able to partner with NHS providers and to be doing this work in collaboration and with the support from the Health Foundation and NHS England. That means that we can really draw on the extensive kind of work that's happened on this topic, and both from our organisations, but most importantly from the networks and people that we're able to draw in, including from Q. Really excited by the speakers that we've got lined up for us here. So really happy to welcome Ruth Robertson, who'll speak first. She's a Senior Fellow at the King's Fund. We'll then move on to Russell Nightingale, who's the Chief Operating Officer at Harrogate and District Foundation Trust and also has a role at Wyatt. And then we'll move on to Chris McCann, who is the Director of Communications Campaigns and Insight at Healthwatch. We'll have time for Q&A as we go through, and then we'll have a more substantial kind of chunk at the end for some discussion. Just to help kind of prompt your thinking and reflection as we go, we shared in advance a reflections canvas. That sounds like quite a over-the-top word for something that's really a piece of paper that you can separate into four to help kind of guide your thinking. We've kind of got it on screen here, or we'll post it in the chat, or if you do have pen and paper to hand, we found it can be helpful to, as you go, be listening out to what are you hearing that relates to improvement? What are you hearing that relates to work around kind of collaborative working? And what is it that you're hearing that feels particularly important around equity? So that's only for your own use, but as we come to the Q&A at the end and the discussion, it would be great to get people to share a few of their reflections. That kind of bottom right-hand quadrant might be a place where you're able to draw on the different things that you're hearing and thinking about what do you take away that you can apply to your own organisation and collaborative. Interested to hear how that works for you. Just a few housekeeping notes before we get going. So it's an interactive event, so please do keep your cameras on throughout if possible, but please do mute your kind of microphone if you're not participating, because otherwise the kind of background noise can really interfere with the session. If you lose connectivity, you can follow the same link to rejoin. We really welcome your questions and comments. As I say, multiple touch points for questions throughout the session. You can raise your hand or post questions in the chat as they occur to you, and then we can bring people in at those kind of points in the session. If you haven't done already, it would be great if you could introduce yourself in the chat, maybe share something that you'd like to get out of today's session. Please note that the session is being recorded so that we can share the presentations afterwards on our website and promote it to members. Okay, so that's the main kind of context setting for this session. I'm going to hand over now to Ruth to lead us into the first presentation. Ruth, over to you.
Thank you so much, Penny. And I love the idea of a reflection canvas. I feel like that's something I can already take away from the session. But thanks so much for having me here to talk to you today. I'm a policy analyst and researcher, and I work at the King's Fund. For those of you who don't know us as an organisation, we're a health charity, and I work in the kind of think tank part of the organisation. So doing research about health policies and how they're operating or working in the health and care system, and sort of trying to support improvements. So I'm talking to you today because I recently completed some research funded by the Health Foundation that's looking at progress with tackling the elective care backlog in an inclusive way. And I'm going to give you a bit of a whistle-stop tour through that work today. I think I've got about 10 minutes. So I'm just going to skip through things, but we have got a big chunky research report, a summary and a slide pack about this work. So if you want more information, do take a look at that on our website. And I think someone's going to share a link in the chat as well. Next slide, please. So before I get into the research, I just want to talk a little bit about the policy background to the topic today. If you cast your mind back to the summer of 2020, just after the first wave of the COVID-19 pandemic, NHS England at that time asked, you may remember, trusts and systems to take an inclusive approach when recovering services. It was part of this idea that we're going to build back better. So not just recover services, but actually start to address some of those really deep health inequalities that have existed for a long time, but they were really put into the spotlight during the pandemic, when we saw so vividly how different groups were affected in different ways by the virus. So NHS England asked organisations to start that work by looking at their waiting list, disaggregating the waiting list by ethnicity and deprivation. Those are factors where inequalities had got wider during the pandemic, and identifying inequalities and then taking some action in response. So that was the work, bringing together elective recovery and action on health inequalities. And when I heard about this policy, I was immediately very interested in it. It's doing exactly what at the King's Fund is one of the things we think is so important for the NHS to make progress with tackling health inequalities. And that's putting work to tackle health inequalities sort of slap bang in the middle of a core operational process, managing the waiting list. So really trying to make that work part of the NHS's business as usual. So when I heard about this, I immediately wanted to find out what was happening in response to the policy. Was it working? Was it having an impact? Next slide, please. So just to say a few words about what inequalities on waiting lists are. I think people might initially think, wait a minute, health inequalities exist in the wider community outside of hospital. But once you get on that waiting list, you're in line, you're waiting in order to be treated. Where's the inequality? But this slide is just talking about the fact that people from different groups experience different lengths of wait for reasons that aren't just about clinical factors. And also waiting can have a different impact on different people, depending on their circumstances. On the left-hand side of the slide, I've included a piece of analysis we did that just illustrates what those inequalities can look like at a national level. We analysed some referral to treatment time data last year from August 2022, and the analysis shows that people who live in the most deprived parts of England are more than 2 times as likely to wait over a year for elective care compared to people who live in the least deprived areas. And there's a whole range of reasons why that might be the case. Those reasons are obviously going to differ in different areas, for different specialties, for different groups. But you can see some of them set out on that slide. Next slide, please. So this slide is about our research. We did a piece of case study work looking in depth at 3 trusts and their connected integrated care board. And we also did some interviews with people using artificial intelligence to prioritise care. We reviewed board papers from a wider set of trusts and ICBs, did some data analysis and literature review. We found this work is at a really early stage, work on inclusive backlog reduction. Our research took place between December 2022 and June 2023. A lot of the organisations we looked at were yet to take that first step of looking at their data to see what inequalities existed. I'm interested to know what stage people on this call are at. I guess we are a bit of a self-selecting group of people interested in the topic. But we found that even despite there being a kind of specific operational plan ask around reporting disaggregated data to trust and ICB boards, for example, that wasn't happening in any of the sample of ICB papers we looked at in our board paper review, and in the majority of trusts it wasn't happening either. There was a whole range of reasons for the lack of progress, and I'm sure these reasons will be very familiar to anybody who's trying to make change or bring improvements within the context of the NHS. They relate to the kind of mechanical nuts and bolts, so a lack of analytical capacity, for example. There was a lot there about culture and staff engagement. And we heard quite a lot of resistance from clinicians and other operational staff, particularly to the idea of pushing some people up the waiting list. Different views of what a fair approach to managing waiting lists would look like, what fairness means in this context. Also some confusion about what it would mean to do this work and what the vision was, why it was necessary in the case for change. And then the final point I'll mention on there is about accountability. And I think this was something that we heard in almost every conversation we had. 39 interviews in all we conducted with people in NHS regions, in integrated care boards and in trusts. Accountability for elective recovery and waiting times performance is about reducing long waits and health inequalities. Work to address inequalities was not getting a look into those performance conversations. I think that will probably be familiar to people on the call, that this is something the NHS has been asked to do, but it's not something that it is being held to account for at the moment. Next slide, please. Having said that, I didn't want to come across too negative, because actually we did find out about quite a few effective initiatives that were addressing inequalities, and these happen at different points along the patient pathway. There's just a few examples that some of you may be familiar with that I've highlighted there. They include things like prehabilitation, so working with people while they are on the waiting list to make sure they're in the best possible health to be able to have a treatment when they reach the top of the list. There's an example from Cheshire and Merseyside integrated care board there, where they identified patients at particularly high risk of deterioration, and piloted an approach where they put a health coach in place. People who had that health coaching had various positive outcomes compared to a control, like reductions in post-operative complications and various other factors. Coventry and Warwickshire, you'll probably be familiar if you're interested in this topic. They're the kind of most famous example, I guess, of looking at reprioritizing waiting lists and using a kind of wider set of data to assess clinical risk and the order that people should be treated. And then some fairly kind of simple but effective interventions on things like missed appointments. And I've highlighted work by University Hospital of Leicester there, where they used various pieces of data, including deprivation status, to identify people at high risk of missing their appointments. They then call those people, offer them a range of supports to help them get to their appointment. And they saw the rates of missed appointments in that group dropping to around 1% in a particular pilot, and compared to around 50% for people who weren't contacted. So those are just a few examples. And one thing I just wanted to say about most of the interventions we heard about were about stopping people falling down the list. So making sure people are able to make their appointments once they reach the top of the list, or in a healthy state to get treatment. They were about stopping people falling down the list rather than pushing people up the list in most cases. And I just highlight that because of that point we heard in terms of the barriers around resistance from people worried about what's fair. Now, I can see I'm slightly going over time, so I'm going to just quickly on the next slide mention that there are a whole range of things that we suggest will be good to focus on to progress this work. They're coupled around making the case for change. And, many of the people we spoke to were not sure about what addressing inequalities in waiting lists meant. why it was important and whether it was a priority locally. So I think there's a real task at, we want to make progress with this at national, regional, kind of more local level to make that case for change. Lots of stuff in there about how you can take action and how this doesn't always need to be a very controversial endeavour. And we make a whole load of recommendations about holding ICBs and trusts to account. I think if we want to make progress on this, accountability isn't the be all and end all, but it needs to be part of the way that we judge whether elective recovery has been successful. Part of that must be whether inequalities have been addressed as part of this. Next slide, please. I won't go through these recommendations for trusts, but just to say where we saw things working really well, it was where once these inequalities had been identified, trusts were working with local communities to really understand why those inequalities were there and to build quite often time needed to be put into building trust and in order to address them. Next slide. Some questions there to think about in relation to your organisation. Many of the people we spoke to said they just couldn't start to address inequalities on waiting lists until long waits have been addressed. I want to encourage you to challenge yourself on that. We saw progress in places that had some of the longest waiting times in the country. Yeah, sometimes tackling inequalities will make the whole system work in a more productive way and kind of be resource saving. Yes, sometimes it won't, and it will require extra resource, but I think kind of without looking at the data and understanding what you're dealing with, you have no way of knowing. My feeling at the end of this research was that this work is really important and it's doable, and that was something I wasn't sure about on going into the piece of work. So I'm really interested to know whether you agree and kind of what your thoughts are on doing this work locally. Next slide. I don't want to finish without thanking all of the researchers and coordinators in our team who worked on this at various points, and the Health Foundation for funding this piece of research. And final slide, there's a link to our report, and also if there's stuff you're doing on inclusive recovery, I'd be so interested to hear about it. So there I have my contact details as well. Thank you.
Thank you very much, Ruth. That was kind of fabulous to hear. So yeah, I'd really encourage people to put comments or questions in the chat. We've got a couple of minutes now before we move on to the next speaker. There'll be more time towards the end. Perhaps while people are thinking about that, I mean, you've talked about the need to engage kind of staff effectively in that context of different views around fairness and confusion. Did you see any particular good practice in the approach that people took to engagement, or any particular things to avoid? And yeah, really interested if others share examples in the chat too.
Yeah, I mean, one of the kind of simplest and most compelling ways this was being done was by taking data, a particular divisional director, looking at her waiting list, identifying some inequalities, particularly around DNAs actually, and then going around and showing that to her clinical leads and just kind of explained to them what it looked like. And she found that was very powerful. So just those kind of one-to-one conversations with the data kind of bring it to life, because I think inequalities on waiting lists, the doctors were just thinking, what is this? What's my role in that? I don't really understand. But going to them with the data about their patients and saying, here's some things we're thinking of doing about it, was very effective.
Interesting. And generally the data was available to do that well? Or was that a barrier as well?
It was a barrier. And actually that particular person I'm talking about had kind of been grabbing around looking for support, hadn't been able to get it, but had just kind of tried to make do and mend, I guess, with the data that she was able to access, and she was able to get something good enough to kind of identify some areas for action and kind of make a positive change. So yeah.
Yeah, and in Q we've been learning just the complexities of people trying to work with the data in this territory, and on the one hand really needing to dig into the complexities of that, but at the same time feeling this strong urgency to move to action and making good use of the data there is. Anyway, a couple of questions come through in the chat. So Dr. Jamil, I don't know if you'd like to come off mute and ask your question, otherwise I could just feed it in.
Sure. I just don't have much of a voice at the moment, but you can hear me sort of.
We hear you well.
So thank you very much for that a whistle-stop tour of that report. It was really helpful. I will certainly look it up. One of the things I've been struggling to get my arms around is around a dynamic assessment of harms while patients are waiting. And I don't know if some of your work touched upon that as well, because we can slice and dice the data that we've got in front of us, but then they're still waiting for 6 months or for 12 months. And so how we dynamically assess them as we go, as they wait.
Yeah, my colleague Nick, who was a co-author on this, spoke to quite a lot of people about how, I know she's on the call, about how they were using a whole range of data and artificial intelligence and kind of models to assess risk and update it fairly regularly in a dynamic way. But I'm not sure I have any like specific solutions. I just know that's something that people were working with data companies to try and do. Yeah, so I don't have a great answer for you on that. Don't know if Nick wants
It's
to.
often useful insight to surface the gaps. I mean, if there's anybody else on the call who has insight into that, please do flag it in the chat. Maybe we could come back to it a little later. Yeah, I wonder actually, maybe I'll bring in Helena if that's all right. She's got a question in the chat about.
I'll come off mute.
Yeah, please.
Hi, hello. So I'm Helena Foss, I'm a consultant in public health trust lead for health inequalities, and always say not an analyst, but obviously with public health training and background, very interested in the so what. So very aware that you know, we will all have a huge amount of data and the ability to analyse at different levels, different cuts, different time periods, and would really interested to know if there are some standard methodologies that we could be taking forward to help us move past that point of saying, well, what are the confidence intervals? Is that down to small numbers? Are we better analysing at a large geography, because then you might have larger cohorts? Just I think some of that, those kind of nuts and bolts of, this is a standard methodology to run, let's run it and move on. I think I'd be really interested to hear from others. You know, I think, you know, as somebody who's come through public health training, if the confidence intervals aren't there, you know, and there's, you know, you're sort of, it's difficult to know whether the variation you're observing is just unexplained. It isn't, it's not necessarily unwarranted. So I'd be really welcome, yeah, someone else, but it does feel like each trust, ICB is reinventing the wheel. Obviously aware, and someone shared a huge amount of health inequality indicators coming out, but it feels for me that this is more around saying, you know, analyse at a system level across all specialties, then cut down the next level. You know, we agree that the time period we're looking at is which waiting list time period. You know, there's how many weeks, there's this period, over what time, you know, those sorts of things. It does feel on a very personal level that there is a potential risk of spending an awful lot of time trying to agree what the methodology is, which can take up a lot of time.
Should I come in quickly, Penny? Yeah, and I'm sure others on the call would have a lot to say on this, but just to say, we heard again and again calls for kind of national guidance and support with, you know, there is a national health inequalities dashboard, but you know, more support with that and to get it more to a more granular level. I would say a couple of areas we saw were making progress on this. We're working quite closely with their local authority public health team to help them understand the data a bit more, because there were examples where people did this first cut and they were just like, this is weird, I don't understand what this means, and they really needed support. They needed support with the data, but then they also needed to bring together a whole range of people from different organisations in their system to kind of talk about the data and understand what it meant. And interestingly, it was often, well, I heard a couple of examples where it was as if not more difficult to get that meeting together as it was to get the data together. But that kind of conversation was a really important part of making progress and kind of making the data useful.
Yeah.
Thank you. Maybe this is something we could come back to later. And thank you, Andrew, for sharing the link in the hub in the chat to see a further source that could help us with that. Thank you very much, Ruth. Let's move on to Russell, and then we'll come back to you as we get to the panel conversation bit. So yeah, I'm going to hand over to you now, Russell, to share your presentation. Thanks.
Thanks, Penny. I think I've got control of the screen. Yep, I'm moving now. Hi everyone, I'm Russell Nightingale. I'm the Chief Operating Officer at Harrogate NHS Foundation Trust up in Yorkshire. And I moved here about 3 years ago from London, which is important. I moved here for the weather. And I'm also the elective programme lead, so I'm the SRO for West Yorkshire Association of Acute Trusts. I've been doing that for the last 2.5 years. I'm also now the lead of Humber North Yorkshire collaboration of acute providers, so a different name but the same thing. So 2 collaboratives, and I'm the SRO for the elective programme. Talking about West Yorkshire today, if the slides move on for me. Let's try the arrow there. Maybe that's better. So why does it exist? I think it's really important for context on this call, so you can hopefully sort of see what we're trying to achieve, and then hopefully answer some of those questions Ruth posed earlier regarding why people are not going faster on some of this stuff, because it is really important. So West Yorkshire is made up of 6 acute trusts in West Yorkshire, multiple hospitals, about £3 billion spent across those 6 hospitals. You can see them there: Airedale, Harrogate, Bradford, Leeds, Calderdale and Huddersfield, and Mid Yorkshire. So we are an acute collaborative, I think one of the oldest in the country, been running around 7 years, so fairly well set up, a really good sort of collaborative approach to problems. We are part of West Yorkshire, and I head up a group called the Elective Coordination Group. So we are responsible, both have the autonomy and the responsibility for all things elective across those 6 trusts. So the other 5 trusts have relinquished their responsibility on a number of work streams, and we pick them up as a group of 6. That group of 6 is wider. This is us 2.5 years ago, in the midst of COVID, getting together the first time for our inaugural meeting face to face to work out how we're going to tackle some of these wicked challenges, not just inequalities, but waiting list issues that we all faced across our 6 providers. That's grown into a group of each provider provides a deputy Q or director of operations with a clinical director for surgery primarily. So each trust has 2 representatives at our weekly meeting. That's our cadence, and then a quarterly face-to-face that we do each quarter going forward. I'll talk about that a bit later. When we met 2.5 years ago, we pulled together an ethos of what we are and what we do. Overarching, we're in this together. One fails, we all fail, and we all sort of believe in that. It may sound a bit sort of trite, but we all do believe in that. And then we came up with sort of 5 priorities. So treat as many patients as quickly and safely as possible. So a pretty obvious one, I'm sure, which we all have, any collaborative or any provider you're in. Sharing best practice. So 6 providers, there's some large providers in there. If you look at any sort of model hospital data, model system GIRF, the inequalities between our hospitals were vast. So how do we even learn from each other locally before we start having meetings with Tim Briggs about national positions? And then shared use of the independent sector. So we all had access to different levels of independent sector, especially around the city of Leeds, obviously. Leeds are sort of keeping that all to themselves. So how can we have a conversation about sharing that access to the independent sector and also holding the independent sector to account? So we set up a working group which meet weekly, reporting to ECG. Collaboration on workforce. So I'll talk about that later, what we've done on the workforce. And then lastly, that consistent approach. 2.5 years ago, we took on that narrative of how do we ensure there's equity of access across West Yorkshire, and that was one of our sort of top 5, and that's why it's in bold. And underpinning our group is radical candor. So you know, we are really honest and open with each other. There's no kind of veiled secrets, and we do what we say we'll do. So if we say we're going to do something, we do it, and we hold each other to account. What have we achieved? Appreciate this is a bit of a text list, but I'll hopefully give you some detail. So we tried mutual aid. We tried in vain in mutual aid, and we managed to move around sort of 30 patients in about 2 months. It was rubbish. So we phoned the patients and asked them why it was so poor. And primarily what we were asking is, we were calling between 9 and 5, people generally at work, and we were asking really low-banded people to have conversations about moving hospitals. About hospital, they had no idea what the hospital was or what they did or where people could park or where people could stay. So we designed a script on what individuals would say. We decided that the receiving trust would do all of the calling because they could answer the questions about the car parking, you know, etc., how much it costs, and if there was a WHMF on site, and all the questions that patients might want to ask. Then the next thing was around money. So would we pay for travel for patients? Would we pay for travel for companions or families? So we agreed that as a group of 6 trusts, we put together a little sort of fund together that we all sort of funded, and we offered that to patients up to a limit of £250. They could travel to cover taxi costs to hotels if required, and we obviously put them off in those hotels. So took some of those barriers away. We did that quite quickly. That was obviously a huge success. So we agreed our framework, and we've IPT'd over 3,000 patients in 20 months. I'd probably hazard a guess that's probably the highest in the country. We've taken a collective approach to independent sector, and we've driven the utilisation through the independent sector, and that's it's been great. So offering a patient an appointment tomorrow, but they've got to travel 30 miles. It was kind of DMAS before DMAS existed, or PIDMAS before PIDMAS existed. People were really keen to take us up on those opportunities to be seen next week in a private provider. We designed the West Yorkshire Associations of Trust passport for staff. So we did feel a little bit that it wasn't fair moving patients around. So how could we move staff around? So we designed a passport to take around all the governance elements that we felt were a bit archaic. Why clinicians couldn't operate in different spaces within our sort of catchment area. And that works really well now. So we've got surgeons operating in different hospitals with different teams, anaesthetists moving, theatre staff moving between hospitals to make sure we're trying to drive 7-day working, sort of 3-session days at all of our 6 trusts. The GIRF action plan was relinquished by Acute Trust, and that was given to ECG, so we run that now centrally. And then we started taking on more work because we were quite successful on delivery. So collaboration on digital initiatives, so RPA, robotic process automation, and PIFU primarily, which we know makes a real difference to people waiting. I mentioned the quarterly face-to-face element. One of the things we've done recently is a shared access policy. So when we got into some of the inequalities element, what we realised is our 6 trusts had 6 different access policies, and the way we treated patients, 2 DNAs and you're out, or 1 DNA and you're out. Clinicians need to sign off, clinicians don't. Some of those things, people weren't. It wasn't a level playing field across. So we couldn't all work together unless that was together and that was on the same page. So we amended that. Now we've got a shared access policy across our 6 providers. We did some targeted work on colorectal at Leeds. So Leeds had a really sticky issue on colorectal patients, that sort of tertiary centre, large hospital trust, and they were using a lot of their allocated slots for sort of, more DGH work for colorectal. So we, as the other 5 trusts, pulled all of that work out from Leeds and prioritised that work so Leeds could work on their sort of more complex colorectal patients, and we reduced their ICU waiting list by 43% in 12 months. And then lastly, and probably again our most important, that's why I put it in bold, we designed and implemented clinical networks. So we realised that we could do an element of sustainable change through our operational groups, but actually to drive real change and transform pathways and make a difference to patients, we needed clinical networks. And we set 9 of those up around the high volume, low complexity specialties that you'll all be acutely aware of, and that's been probably our greatest success actually in 2.5 years. So now we meet quarterly. The picture in the middle is the huge group of us, because that's our clinical network leads coming together. And this for me is really, really important, that engagement piece. So any collaborative you're in, any elements you work in a collaborative, I think it's important that people can get together, have conversations and share their lived experiences. Obviously we're data driven. So this is our problem currently that we have. So everyone knows the 65-week position needs to be sort of 0 by March. All the patients are on your waiting list already, primarily, so you know them. So for us in West Yorkshire, 20,000 patients, nearly even split, but non-admitted at 11,500, admitted at 8,000, just under 8,500. The ones that are waiting for appointments, the ones that aren't, the ones who've got booked, etc. So we monitor this weekly, so we're really data driven. So we know the ins and outs of all of these sort of the waiting list and where the problems are. So gynae is our main issue there. Primarily it's non-admitted patients. So we're working through our plan, through our gynae network, on how do we share some of that load of patients to make sure that they're not all stuck. They patients currently Leeds. Again, how do we support sort of Leeds in that element of work? So all of that's great, and we've done loads of things, but have we done it equitably? And the answer to that is probably not as well as we have. So we were a bit like, this needs to come after this one. We were a bit like this. This is a ChatGPT image, DALL-E. Anyway, we were sat around thinking this is a really important thing, and we've seen this guidance come out, as Ruth mentioned, but it was like, yeah, do we really want to do that? Like, we just need to clear these patients. That's our main priority. It's being really honest and candid with everyone. It really wasn't our priority. And at our away day, we had a really mixed view of people saying, well, we're not racist in our organisation. We treat everyone fairly, and we don't ever see the names, and we don't even know the IMD access, sort of quintile. So we had lots of those sort of conversations at the beginning. Different views, different things, different ways to approach. So we decided to do what we do best, is look outwards and upwards and shamelessly steal. So we had University Hospital Leicester come and present to us on some of the work they've been doing. and it was absolutely fantastic on the DNA rate. And I remember a statistic I was told that 3% DNA rate for a white female for a breast 2-way appointment is 3%. For a black female, it's 30% DNA rate. So for us, it was about those bits of the things we can control. How can we get people to their appointments? So what is that telling us across West Yorkshire? You know, what do we know about some of these patients on our waiting list, and how do we get them into our system quicker? Because we feel quite assured that when they're in, obviously there's a bit about people know how to play some of the systems, but when we get them in, we know they're in our system. We'll have better sort of data understanding of them. This is really important because this played a massive part in some of this, because once we know the data, what we're going to do about it, we will have to act in the same way and behave in the same way. So it's really important we're using the same playing field there. On our DNA rates, there's a better slide here. No, it's been taken out. On our DNA rates, we analysed all of the data. 14 million appointments across 3 years. 1 million of those appointments were DNA appointments. If you looked at those million appointments, 47% of them were in IMD 1 and 2. So 40, just under half were in 2 quintiles. So we did some analysis on that. We engaged some volunteers to speak to patients, to call anyone we could, anyone would answer, send out text messages to say why did you not come? So you're going to get your appointment again, but why did you not come? There were lots of elements around that. Language issues, the letters were all in English. PEPs, our patient engagement portals, were primarily all in English. So English wasn't the first language. That wasn't something that was really quite understood. So some work there. An element of patients getting a letter, and the letter was giving the appointment in 6 weeks' time, 8 weeks' time, 10 weeks' time, and then people forgetting and not turning up. So again, we introduced reminders at 2, 7, 14, 21 days, and we do those reminders out of hours. So we sort of have people working from sort of 6 till 9 p.m. to do the calls rather than during the day, because it doesn't really work doing any calling in the day for a lot of these patients. So we put together an action plan, and we've been driving that through our elective coordination group, sort of moving from a transactional group of delivering 65 weeks 0, which we will deliver, but to more transformational and thinking a bit further ahead, because I think more and more acute providers and collaboratives will need to, because a lot of that waiting list is now non-admitted. A lot of the waiting list, you've done all your tail gunning, now it will be non-admitted patients. So the only way you can remedy some of that is reducing this DNA burden, which will have a proxy impact on equity of access, and you'll know more because they'll be in your system. So a huge focus for us on DNA, and that's going to be our priority for the next year. We want to sort of overtake University Hospital Leicester, because we're really competitive on some of the work they've done and some of the stats Ruth presented on the 1% DNA rate. So that's a good program of work. But then we thought, is it enough? Are we doing enough for our patients? And we decided we weren't. So we wanted to look at a specific group of patients where we could make a direct impact quickly. So we decided learning disabilities. So we've got this access policy across West Yorkshire, and we know which patients in our system have learning difficulties. Now I'm going to caveat that, because currently across our system we have 0.4% identified patients in our system on a waiting list that have an LD flag notified. But we know, in our patch, it's about 1.2% of the population have learning disabilities. So for us, it was around, how do we engage that? How do we improve the uptake of us knowing? So that's a secondary ask. But our first ask is that if there is an LD flag in the system, an acute provider, and a patient is listed for an outpatient or an admitted patient, we prioritise those patients within their P category. So if you're a P3 and you have an LD flag, you will be bumped to the top of the list. So that element that Ruth mentioned about prioritising patients, we're doing that, and we're doing that with learning disabilities, and we've been doing that for the last 3 weeks, and hopefully we'll be able to come back in the future and say what a difference it's made. For us, we know the uptake's not enough, and we want to capture everyone, but it's just something we thought was tangible that we could easily invoke because of our access policy, to get these patients prioritised in a quick fashion. That was everything I wanted to cover. Obviously, I can take any questions. Thanks, Penny.
That was brilliant, Russell. Thank you very much. Again, really encourage people to put their questions in the chat or come in with comments at this stage. Again, just to get you going, I was really interested by the kind of story of collaboration, kind of pooling your resource and activity in a really kind of critical area. Can you say a little bit more about what enabled that collaboration, and if there was anything that was different as you moved from the more transactional work to the more transformational work that you described you describe moving to?
Yeah, so I think firstly, it's really important to say that, you know, as Ruth said, this is really, really important to people, but we're asking people that are spinning 30, 40 plates at the same time to spin another plate, right? So, and like you say, it's not a diktat, and we're quite good with diktats, and we just do what we're told. So for us, it was really important that we as a group of chief operating officers in West Yorkshire, sort of really honest with each other at the start and said, we can't all achieve all the things we're being asked to deliver. So why don't we take one strand each? So I take elective, Saj takes cancer, the coup from Bradford, Claire's taken the UEC element from Leeds. So we've taken those strands. And what we've done is sort of almost shared our collective workforce of operational clinical leaders to come together under those elements. It doesn't matter that I'm not their line manager. It doesn't matter that they don't report to me. What matters is we have this kind of this focus of improving something. So for us, it's elective access, and that's our task together. And we have the autonomy and the responsibility to do that. So we take it really seriously what we do, but also we have the autonomy to change. So changing an access policy in my own trust previously has been difficult, but changing it across 6 trusts, it took us a week because we said this is the right thing to do for patients, and I was presenting it as coup to coups. So it just made it quite easy. And I think that, and I know we've been going longer as a collaborative for 7 years, but it's just that ethos that we have in all of our leadership teams at an exec level as well around, we don't want anyone to fail. So our mutual aid has been successful. We at Harrogate have been, we've taken in the past previously, 104-week waiters from Airedale, and I've had to present at board, but it's really important that NEDs and boards understand that Harrogate presenting 10 patients they didn't have last month on 104 weeks is not great, but actually it's about we're going to take them because we can treat them faster than Airedale. So yes, I'm up for scrutiny, but it's about we need to have that level of understanding of why we're doing things.
Yeah, I mean, a fabulous set of slides. I have to say my favourite one were the pictures of the group of you as individuals coming together. It captured something important about this being about a set of people taking joint responsibility at the right level in organisations, as opposed to a kind of institutionalised understanding of what a provider collaborative means. I don't know if anyone else has any comments or questions they'd like to add into the chat. And indeed, if anyone is producing their reflection canvas, you won't be able to see this. I'm quite glad because mine's very messy. But I was really struck by some of the sound improvement principles. So your kind of focus on data for improvement. I really loved the kind of flipping of moving staff rather than moving patients. And I'm kind of curious about whether there's other ways in which we could be flipping some of our assumptions about how we tackle this in order to unlock other issues. And then perhaps particularly thinking about actually, in order to make progress, focusing on one particular area. And maybe if I could just ask a question about that before we move on to the next speaker. It can be quite hard to decide actually to make more progress. We're going to focus on this particular group. Can you tell us a little bit more about how you decided to do the additional focus on people with learning disabilities and what that unlocked?
So interestingly, because we've got 6 providers, I generally think across whatever collaborative you work in, you have some really good people doing good things. And Mid Yorkshire, I know, are on the chat, but Mid Yorkshire were doing this already. Mid Yorkshire had a really good process. They'd hired a learning disabilities nurse for improvement, and they were driving change already. So we just, again, shamelessly steal things. CHFT were doing something very similar to Mid Yorkshire. They were miles ahead of the other 4 of us. Sort of, so we just asked Mid Yorkshire to come and present, CHFT to come and present, and we kind of stole the best bits. And then we agreed as a group that this was the right thing to do. So I think that's the thing for me in my learning in this 2.5 years of doing this role is like, as Ruth presented, they're a trust doing great things, sort of way ahead of everyone. Just pick up the phone and tweet them, just kind of ask them what they're doing, and people are really keen to share their best practice and then just give it a go. I think that's one thing we need to keep trying, but sometimes we get reluctance, or we're scared because it's patients. We're scared because we're doing the right thing. Well, I always think if somebody's done it and no harm is coming of that, let's just give it a go. And if we can treat more patients, even better. Indeed,
there's a kind of mix of cultural and practical barriers to that, picking up the phone and asking others. Something we try and counter in Q, but yeah, and through the things like this webinar, I guess. Let's move on now to our last speaker, and then we'll bring you back in when we get to the panel. So I'm going to hand over now to Chris from Healthwatch. Over to you, Chris.
Hi, everybody. So I'm Chris McCann. I am the Director of Communications, Insight and Campaigns at Healthwatch England. If we could just move on to the next slide. So hopefully most of you are aware of what Healthwatch is, but I just thought it was worth setting out at the start who we are and what we do. So we are the Health and Social Care Champion for England. So we have the remit for gathering feedback from the public of their experience of health and care and using that to improve the delivery of services, the delivery of policies. There's a local Healthwatch in every tier 1 local authority area in England. So there's 152. We are completely independent and impartial. And as I said, our job is to try and understand patient experience and feed the insight we get from that back into the system in order to improve people's experience of health and care. So if we could move on to the next slide. So I think what's important to say at the start is that when we talk about waiting, quite often we talk about the numbers. You hear the 7 million figure bandied about, or you hear the 52-week waiters, etc. But it's important to understand that it's not just about the length of the wait. When we talk to the public, the quality of their wait for care is almost as important as how long they have to wait for care. People understand that the system is under pressure, and they understand that there's a substantial chance they may have to wait some time for care. But what they can't understand is sometimes how they are left feeling as if they don't know what's happening and feel as if they've gone into a black hole. So just in terms of the patient experience that I'm going to talk about, I'm going to go through it sort of stage by stage, from where the patient gets referred by their GP to a specialist for a scan, test, or treatment, through to their experience of actually waiting for treatment once they've got their referral, had their initial consultation, etc. So if we could just move on to the next slide, sorry. Now, I appreciate that talking about GP services is a little bit out of scope for the audience that's here, but I think it's worth remembering the fact that getting a referral from a GP is pretty much, nearly always the first step on that patient journey, and that can actually be quite a challenging process and can be quite a stressful one for a member of the public who's waiting for treatment. They can often takes them more than one GP appointment to get the consultation that they need. Quite often it can take them some time to actually even get access to their GPs. I think we're all aware of that sort of 8 a.m. rush. So actually the first step that could be taken to improve patient experience of waiting is making that front door a bit easier to get through. So better access to GPs appointments, better telephony systems, other options for care navigation, greater appointment flexibility, and clearer and regular communication between staff and patients. And that communication point is one that we'll come back to every bit of the way along the journey, because it's really key. So moving on from getting a referral, if we could go on to the next slide. Again, people's experience of and delays for scans and diagnostic tests means that they're often left sort of waiting for a long time in order to find out what their condition is, or once they've sort of established what their condition is, what the next steps are for treatment. And people also often end up feeling pressured that they have to go and find out for themselves, or to understand what their next step is, rather than actually just waiting for contact, because it can feel that they go into what some of the people we spoke to felt like a bit of a referrals black hole. So searching for answers can lead to frustration as people find different services in different parts of the system manage their referral journey. The way data doesn't flow across systems doesn't make it easy for people. And there's a couple of steps that could help on that. So again, I'm going to come back to clear and timely communication. It's important that patients understand what tests they're undergoing, why they are being done, and what's likely to be the next steps. And then once scans and tests have been completed, people need to know when they can expect results. Is it going to take a matter of days? Is it going to be weeks? So that at least they're not left with that sort of sense of anticipation and feeling that they're delayed and forgotten about. And we know that at this stage that there are, there's really sort of differing experiences in terms of different groups on how they experience that wait for a referral. We know that people in higher wealth tend to be able to navigate that process more quickly and with less stress than people from less prosperous backgrounds. And similarly, we see that pattern repeated across the piece in terms of people from minority ethnic backgrounds find it more challenging. People with a disability find it more challenging. So that process of getting diagnosed can again be one that puts the patient under unnecessary stress. If we could just move on. So then, as I said, when it comes to getting treatment, the public, they see the news, they know what's happening in their local hospital. They're aware that there are likely to be substantial waits for them to receive the treatment that they need. But what they really makes them feel stressed and really increases the detriment of their wait is a sense of uncertainty about when they might be expected to receive treatment. So feedback shared with us shows that people are happy to accept, well, not happy to accept, but are prepared to accept waiting times for elective care, as long as they have a bit of certainty. They know they're going to get treated in that date. But if procedures are, say, related to mobility, people's life can be left on hold, and subsequent cancellations and delays can make people feel forgotten. And particularly if people don't know the reasons why a course of treatment has been delayed, or the reason why something has been shifted, that communicating with patients really does reduce the level of stress that they feel while they're going through, what can be a really difficult time while you're waiting for treatment. If we could have the next slide. So we did a specific piece of work this summer around people who had their care disrupted, people who had either delays to care or postponements or cancellations. And we found that the figure for people who actually have their care postponed or cancelled on 2 or more occasions was 39% of the NatRep sample of 1,084 people that we did had their care cancelled on 2 or more occasions, and 18% of people that had their care cancelled or postponed at the last minute, which, as the NHS defines, is either on the day of or on arrival at the appointment. So again, there's some steps that would improve people's experiences of waiting for care. So being clear about why appointments and elective care need rescheduling, and providing a point of contact when care has been postponed, so that people have someone to discuss the implications and what support is available until treatment is received. Do they need extra support on issues like pain relief, mental health, physiotherapy? If we could move on. And in terms of how people experience these delays and these issues, we know that from a range of pieces of research that we've done, some of it actually in partnership with Ruth's organisation at the King's Fund, that the impact of waiting is not felt equally. So long delays for treatment, last minute cancellations, lack of personalised information, that's really a really huge support for a really huge issue for people, but particularly from respondents from lower income households. We know that people from lower income households tend to be much less happy with the level of information that they receive about their treatment and about their wait. We know that disabled people, those with lower levels of wealth, we know that women and people from minority ethnic backgrounds are the most likely groups to have experienced long waits for treatment and a delay or a cancellation. We know that women and disabled people are the most likely to have been most negatively impacted by their long wait for care, with things like relationships, their ability to socialise, their ability to provide caring duties for someone else, their mental health and general well-being suffering as a result. And we know that people with lower levels of education are more likely than people with higher levels of education to be unhappy with information that the NHS has provided them. And we know that where those identities intersect, that across several groups, the impacts of long waits can be much worse. So one piece of research we've done showed that people from minority ethnic backgrounds from lower income households were much more likely to have had their treatment delayed or cancelled at 63% than people from white British backgrounds from a higher wealth household, where the figure was 38%. So that's a 63% and 38% as a real disparity. And then just finally onto my last slide, how you can improve people's experiences of waiting. And the key for this, as I've repeated throughout, is communication. So you've got to provide personalized, clear, accurate, and consistent information to people when they're waiting for NHS treatment, whether they're waiting for consultation and surgery, and letting them know where they are on the waiting list. And a key part of that is making sure that your information is accessible. You know, the Accessible Information Standard has been in place since 2016. I know the NHS is very close to relaunching a revised version of that, but making sure that information is available to people in formats, languages, etc., that they can actually understand is really important. Keeping people informed about the next steps for their treatment, making sure that people have a point of contact, so that if they do have an issue or a concern, they know where to go. You know, they don't feel like they're getting pushed from pillar to post. So if you can provide that specific point of contact for a patient, it really provides them a level of assurance that if something comes up, they know who to contact. And then making sure that interim support, such as physiotherapy, pain relief, mental health support is available. Putting in place systems to better manage waiting lists with a focus on diagnostics to identify what is wrong and better prioritize urgent treatment. And then the ability to reprioritize treatment if people's needs change. So that's sort of a wrap up from me. But as I said, the key issue for people while they're waiting is really that key one of communication and not feeling that they're forgotten about.
Thank you very much, Chris. I mean, with the extended waits that are likely to be with us some years, really important that we're properly understanding what's important to patients as they wait. I wonder how you think kind of leaders could help kind of send the right signals to staff so that they are giving priority to the importance of waiting well and equity as part of that, alongside that kind of headline pressure to reduce waiting times. Have you picked up anything on that?
Well, I suppose one of the things that we see is that while a lot of the media headlines are all about the need for extra clinical staff, it's about making sure that there is enough administrative capacity in place to make sure that there are those point of contacts for patients, that they are staying on top of that communication with patients. But again, I think it's making sure you're putting an emphasis on listening to patients, making sure that that's a culture and getting that message out, and making sure that that those accessible formats of information are available for people. So whether it's easy read materials, whether it's materials that aren't in English for people for whom English isn't their first language. So it's making sure that you have the right communication products in place. And there was a piece of work that ourselves and other patient groups did with the NHS back in 2021, Good Patient Communication Guide, which was distributed around, which I think largely because it landed in the middle of the pandemic, probably got a bit lost. But NHS England have recently revamped that. And I think, if leaders were able to put a bit of emphasis on that and make sure that people were aware of that, and it does give a good sort of step-by-step guide on the issues that patients face and how you can go about ensuring good patient communication.
Thank you. We have a question in the chat from Mahmood. I hope I pronounced your name right there. Would you like to unmute and ask that directly?
Sorry, yeah, I was just being a bit flippant. I mean, so my comment was: is there any trust anywhere that hasn't got communication coming up from whatever source of feedback that we see? It feels to me to be right on the money, Chris, in terms of communication is the big thing, both with patients and between teams within a hospital, for example. I think that's where another big source of failure comes as well. It just, I work for Lloyds Banking. I'm a NED, a non-exec director, and I've worked in customer experience for best part of 20 years within the head office of Lloyds Banking Group, and it just seems to me to be such an obvious area for the NHS to improve on, how we treat our patients like customers and engage them like customers. Rather than, I think, the current system where almost patients have to fit with how the system works rather than the other way around.
Yeah.
One of the issues I think, Mahmood, around that as well is, as you highlighted, is the flow of information across systems. So one of the frustrations we hear about from patients on their journey is that quite often, every time they see a different clinician on a step of their journey, they feel they have to explain their condition and their treatment path so far from scratch, which is obviously a source of great frustration, you know. And I know there are issues as to why some of the sort of legacy systems that are used across the NHS that make it difficult. But if we could break down that stuff around data flows, I think it would make a massive difference, not just in terms of patient experience, but also I think in terms of efficiencies, in terms of the speed that people were seeing.
Thank you. And maybe perhaps, Mahmood, while you're here, I wonder if you have any reflections about the role of non-executive directors in this agenda, either Chris or Mahmood. What role could they be playing?
Yeah, I mean, I've come in, I've been a NED at Mid Yorkshire for 3 years, and because my background is customer experience, I've probably been quite vocal on the theme of patient experience and or lack of good experience that I've seen, and just, you know, for me, you know, I think someone's put it in the chat as well, you know, customer service. I mean, it's the basics of customer service that we don't do. I think the two things that seem to be a bit of a gap for me from outside looking in is how to be a line manager and how to do customer service are quite big gaps in the NHS, and I don't think that's for me unfixable really, or even unthinkable, that we should think of the NHS as a service industry and therefore do what other service industries do, and really think about being more patient-centric and having good customer service training. And I agree, Chris, you know, I think there's a gap with the patient, I think, in terms of engagement and communication, I think, but as you say, there's a gap within the journey of the patient through the hospital. So you end up repeating yourself as if the first conversation hasn't happened. And that's a massive area of feedback I think we're probably all getting. But what is it we're doing about it is the bit that I'm struggling with in terms of trying to fix the problem. And again, it feels like something that we either can fix individually as trusts, or something could be curated a little bit more centrally, because it's a common problem that we've all got.
Well, one of the measures that we had pushed for was sort of mandatory patient voice representation on ICBs. Now it's not mandatory, but you know, there are parts of the country, there are ICSs where it is happening, and there's ICSs that do it not so well. But you know, I think if we could get that to that point where the expectation is that there's a cultural approach where actually listening to patients is embedded, you know, I think that would be a big jump. Now we're still quite some way away from that, and you know, we're not so naive as to not realize that everybody in the system is working under pressure, and sometimes it feels like everything's on fire, and that there needs to be space created to fit that in.
Thank you. It's kind of interesting to reflect on the signals that we send in terms of the kind of staff and how we reward them. So if managers are not necessarily always that popular, communications managers might be kind of particularly in the line of fire often. And it strikes me that people who are in patient engagement functions within organisations often get very little development or support or professional status. So there may be something about the way in which we're thinking about the staff roles here. Ruth, Russell, why don't I kind of bring you into the conversation now, and then perhaps Helena, we could bring in your question. Do you want to come off on mute and maybe put that first to Chris, and then invite comments from Ruth and Russell, and then we'll move into a wider discussion.
Just, I suppose that customer service word had popped into my mind, and I know there have been sort of, you know, historically we've heard about, you know, hotels training staff in different sectors and et cetera. But another thing I've really observed, so for the first time, I'm actually working within a provider trust, which is hugely insightful, I think, for learning how organisations work, the challenges, etc. And one of the things I was just reflecting on in this conversation is actually, who are the bearers of the news to patients? Are they clinicians? Perhaps they're not. Perhaps they're administrative staff. And actually, how do we support and invest in that workforce? I would imagine that how a message is delivered and the level of trust and relationship with the message giver is an opportunity to, mitigate some of the difficulties around that message. But equally, I would be imagining that if one's role was just about telling people day after day after day that they're, then actually that's, not going to be particularly good for the well-being of our staff who are in these roles. So it just prompted some thoughts really around the support, skills and investment around the staff who are delivering messages.
Chris, I don't know if there's any reflections from you there.
I suppose my reflection is that it shouldn't be a case of like, day after day after day, but it's like making sure that making sure the patients at least have a regular drumbeat of communications. If they haven't heard from you in 4 weeks, for instance, or 6 weeks, that they get a message to say, we haven't forgotten about you. You're on our list. You can expect to receive treatment at X time. And the thing to remember is that there are actually, parts of the system that actually do this quite well, So, there's the opportunity for peer learning on where patient-good communication is carried out well. I don't want to give the impression that it's something that's universally bad across the country, but there are certainly some parts of the country where it's not done so well than others. But it's not about somebody getting a sort of like a weekly update on where they are, but it's just making sure that you go, right, we haven't been in contact with this person for 6 weeks. Let's just make sure that they know that we're still, they're still on our list when they're likely to receive treatment, and also ask that question: is there any support you need while you're waiting?
Thank you. It feels to me like when we're talking about the kind of pressures in the system and maybe the moral injury that sits with staff when they're needing to not deliver the level of care they want to, we often just focus on the clinical staff. But I do wonder whether some of our administrative staff who are also working with impossible to operate systems and are continually having to manage the interactions with patients can perhaps face something similar. But anyway, Ruth, Russell, I don't know if you have things to add on this.
Just one thing that was coming to my mind as I was listening to Helena speak about the kind of pressures on admin staff and the kind of trudge of every day having to make these terrible phone calls. When I was talking to people about this work on inequalities on waiting lists and really looking at their waiting population and starting to try and think differently about how to support them, you got into some really deep conversations with people about what motivated them to work in the NHS, why they were here, what was their kind of core values, and that this work was kind of really kind of sparking that in a way some of their kind of day-to-day drudge, as they kind of might describe it, wasn't. And so it does feel like you don't want people to just be doing everything voluntarily extra in their out of hours, which is often how this kind of work gets progressed. But there is an opportunity there to kind of harness something and support staff to really be getting more satisfaction out of their work through this kind of inclusive recovery stuff. So it just reminded me of some of those conversations and how struck I was by the alignment between this work and a lot of the people who work in the NHS, their values and kind of why they've chosen to work there.
Indeed, and whether some of the basics of improvement, I mean, being able to give people some agency and tools to fix some of the problems around them, it can also help support kind of engagement. Russell.
Obviously, just to answer the question, it will be variable by trusts who does it. A lot of trusts, it's generally lower banded AFC staff that do some of the calls, which is miserable. It's not 100% of their calls in a day, but I think when you look at some of the better trusts that perhaps Chris was mentioning, they're moving to patient engagement portals like Patient Know Best. There are other providers. I'm sure if you book your hair, you're doing it online and you get your app and you get your reminders and you can change and adapt and move it. And I think that's where we need to move to. We need to think of a better future where it isn't administrative staff calling, changing, adapting, and patients actually have a bit more ownership of the scales, and that requires us to be more organised and publish available slots and all of those things. But I think that's probably where we need to get to, because like you say, it's a wicked problem which is going to last many years yet. So I guess ramping up those PEPs and getting those working to make sure the patient is more in control of that rather than being reliant on AFC staff.
Thank you. I would encourage people to chip in from in the chat or raise your hand if you have comments or questions you'd like to put to the panel. Otherwise, I was listening to some of the themes in your presentation. I wonder whether we could come back to the kind of data and stories, perhaps think about the kind of leadership and cultural issues that you were raising. And then it felt like there was perhaps something about the way in which you're collaborating for action. So I've got a couple of questions in each of those areas, but I'll defer to anything that comes through in the chat in the meantime. Just on the data, I guess I was wondering how far the patterns and the issues that are likely to come up around equity and patterns of waiting are likely to be specific to each context, and where they are things that are trends that are likely to occur across different settings. So I don't know whether Ruth, Chris, you'd like to comment on that.
I could just come in quickly of the kind of data and the discussions that I saw, kind of looking at dashboards and information on inequalities. It was very specific to particular specialties, particular subspecialties. You know, it's kind of a very nuanced analysis that needed to be done, which was kind of to the point asked earlier about, can you give a kind of basic guidance on what should be looked at, and the kind of standard framing that should be used to look at the data. I can see that would be useful, but I also just saw people running clinical services having to kind of delve into their own data and finding quite different trends. For example, on the DNAs, who, you know, I think Russell quoted particular figures about the DNA rates for particular cancer patients, but I had a conversation where you know, those were very different for the different sites of the cancer, and yeah, I think it's kind of close piece of tailored analytical work that has to be done, unfortunately, was what I heard.
There's a bit for me, and it's about not just understanding the numbers, it's about getting an understanding of the experiential data that's out there. We've quite a bit of that. So understanding why somebody is DNA for a particular appointment or consultation, you know, and that can be a range of reasons. If you're somebody that's, for instance, on a 0 hours contract, something changes, you have to work, or, you know, you have to get 2 buses and a train to get to you, and you can't afford it, for instance. So it's about having having a deeper understanding of why patients are doing what they're doing, not just what they're doing. That I think that could really help get to the bottom of some of this.
Thank you. Russell, I don't know if you have anything to share on this.
Only from a sort of NHS acute perspective, we had a regional meeting last month, and I think there's going to be a big focus on CYP, so children and young people. That's sort of, they're mentioned as sort of children left behind because there weren't that long waiters, but that when you look at the sort of 45, 52 tranche, there are lots and lots of paediatric patients in there. So that'd be the sort of regional focus for us in the Northeast.
So interesting. We spend so much time at the kind of aggregate data, but what I'm hearing is actually it's really important to get down into specific cohorts and specific kind of drivers behind the inequities that we're seeing. So perhaps in that spirit of learning between places, it's learning about the measurement methodology and principle, the approach to the work, as opposed to being able to kind of transfer the patterns that we're seeing in the data. Yeah, I mean, maybe we could then move on to thinking about, in terms of prioritizing this and engaging people. I'm interested in the leadership behaviours, the questions that senior leaders might pose in order to help staff kind of hone in and prioritise and focus on this. Who would like to come in on that? Lucinda, can I bring you in?
Hello. It's been really good to listen to everybody this afternoon, so thank you for this. I'm Lucinda MacArthur. I'm a non-executive director at a large trust in Lancashire and South Cumbria. I've been in ed there for a year. My background professionally is I was a public health professional. So I think for me, we touched on it before about the role of NEDs and boards, but I look at the volume of information that comes via boards. I think for me, the question's quite simple in terms of what's within the numbers. So how we know how we're assured that data that can look great at quite a high geographical level isn't fundamentally missing the point for certain communities that we are serving. And I think for me, it's quite a simple question to start asking and keep asking at board, because I think invariably we don't. I can think I co-facilitate a leadership program on population health, and when we talk to a number of acutes that come via that, and we've been talking for A&E, who's coming through the door, we get a lot of numbers that are coming through the door and why people are coming through the door, but not where people are coming through the door from. And it's a really quite simple thing to be able to do. I think the other thing we've been using, which I've been an advocate for quite a while, is the work of Professor Chris Bentley on priority wards as well. So we've been asking the question a lot about how does that look for, as Russell was sharing with us before, communities that are in different IMD domains. But what about those priority wards that are in the 20% most deprived and are over contributing to avoidable admissions as compared to those that are in the 20% most deprived that under contribute to the avoidable admissions? There's something protective about those communities, and how in the world of integration can we work with our place-based partners to understand what makes some communities have protective factors, and equally what's missing in other communities, and that could be structural factors or economic or social, whatever they may be. So I just wanted to mention that because I think some of the questions we can ask in the forums that we're in as NEDs and others are really quite simple questions. And if we did start to peel the onion by IMD and also certain protected characteristics, I think that as a task alone would take us a long way. I'm really, really thrilled to hear the work that your collaborative is doing, Russell, because I think the role of provider collaboratives in asking themselves all the same question, and then the power of looking at that at an ICB, ICS level, I think may really catalyse and unlock some real opportunities for this agenda going forward. So.
Yeah, the point I would make for senior leaders is ask the questions about, is your trust, is your ICB collecting demographic data, and if they are, what are they doing with it? You know, how are they using it to address inequalities? Because you know, the collection demographic data is not uniform across the system, and also, you know, it's of no use to anybody if it's just sitting in a hard drive somewhere and not actually being used to help shape you know, commissioning or you know, or delivery of services.
Thank you. Yeah, and indeed, is that data understood on a system level as opposed to within just individual kind of slices of data to allow us to get under the skin of some of the things that Lucinda was talking about there. We're nearly at time. I wonder if I could conclude by asking maybe everyone on the panel perhaps a top tip for people who are kind of earlier on their journey with this sort of work. As you know, our insight suggests most people are still at a relatively early stage. I don't know who would like to go first.
I will.
Go.
I beat you, Ruth. Yeah, I think for me, my own personal learning is don't be scared to ask the wrong question, right? So it's okay to be vulnerable and say, I don't know the answer to that. And I think that, you know, Chris's point is valid about leaders asking questions, but I think as leaders asking questions of themselves as well. And I think we need to, if leaders aren't doing that, they're probably the wrong leaders. So I think we just need to be willing to be vulnerable. And I think that's why West Yorkshire works, is because we're willing to say we don't know the answer. And I think I've been in lots of meetings where people pretend they know the answer, but actually a lot of us don't. So I think that's why it's taken us so long to get on the pitch with some of the sort of the other players, because we've not been honest with ourselves about that, and we're just like, we'll improve inequalities by reducing the waiting list total, but actually that probably isn't the answer. So that's taken us a while to get there, and we're a bright-minded bunch. So I think for me, it's about just be willing to be vulnerable.
Thank you. Ruth?
Yeah, perhaps I would say be curious. You know, Lucinda talked about her role doing training on population health, and I think the waiting list is now a very significant population. It's a significant proportion of the population of England. So we need to be applying some of those population health techniques and curiosity about what that population looks like and the experience they're having to this group. And also not to be intimidated, because some of this stuff is really big, but some of this stuff is about quite simple process improvements, like getting the basics right, and that can have quite a big impact, like some of those examples showed that. So yeah, be curious and not intimidated, I guess.
Thank you, Chris.
For me, it's just as to remember that it's not just about the length of the wait, it's about the quality of the wait, and how an individual experiences that. And I suppose the second point is, and the way to understand that is by communication.
Thank you. That's fabulous. I was struck by what Lucinda said, where trusts might be looking at their data and it all might look good apart from the drill down data. I guess many organisations might be looking at data and it looks so terrible that in itself is also something that gets in the way of people seeing the action that they could be taking and the priority on equity. So thank you. A great set of lessons to end with. So kind of be vulnerable, be curious, be quality and experience focused, and don't be intimidated. I think that's a fabulous place to kind of conclude today. So I'd really just like to thank everybody who's participated, so the delegates as well as the panel. If you are happy to stay in touch with other attendees from today's session, if you wouldn't mind just putting your email in the chat, that will allow us to then share that data. I'd like to make sure that you kind of have clocked the evaluation that we do as part of the session. So there's a QR code here, and we've also put the link into the chat. Please do complete it. We want to make sure that we're responding to the hot topics that are important to you. So, this evaluation will help us shape our future work. We have upcoming events in February and March next year, so please keep a focus on the NHS providers website, and that's where we'll share updates. I think that brings us to the end of today. I just want to end by really deeply thanking Ruth, Russell and Chris, and we will end it there. Thank you.